Well, good morning, everyone. It's a pleasure to be here. I'm Michael McGetty. I'm one of the fellows at Minneapolis Heart Institute. And today I'm talking about DK crush at the left main and how to overcome some challenges.
Not the least of which is working with monos.
Yeah, and my disclosures are a little bit less than Manos, but pick up one day. So our patient is a 71-year-old man, came in with progressive angina. The relevant history is a heel type B dissection. He had no intervention. He had prior cabbage, and he had patent grafts that were shown on a coronary angiogram in the outside facility. He had a patent lemur LAD, radial grafts to both OM and PDA. And then this is the angiogram. I don't have his original coronary angiogram, but that's a picture from during the procedure. As you see, severe left main disease, Medina 111, and although he had patent grafts, he still had severe disease, limiting flow to the LAD, going into two large diagonals into a large circ.
Can I just make one comment? How many of you are fellows here? Raise your hand. So you might hear us saying here that we're, trying to prolapse the wire and retrogradely cross and all that stuff, and that's what we're actually not. We're just hoping that we can cross properly here, but we're trying to make it sound as if we're extremely skilled. So.
Yeah.
Yeah. So even Marcus trying to cross here is hoping it gets across with that prolapse.
True. So the next decision was our strategy, and this is the algorithm we used. We had a bifurcation lesion with a large side branch that needs to be preserved, and we assessed that the likelihood of side branch occlusion was high. And as the angulation was less than 70 degrees, we decided to go with DK crush. So we started with an ultrasound-guided right femoral access. We got a long sheath in, a 45 centimeter. And then we had challenge number one. We tried to engage with an EBU 354, 375. It would not just fit in the left main. So because superior takeoff. So here's what we did. We got a GL4 in, and then we engaged the left main with shown blue, and then through a microcatheter, we exchanged it into a Grand Slam. Using the support of the Grand Slam, we advanced an EBU4, and that went well, and we already started our intervention. Then we were faced by challenge number two. We could not cross the LAD. It was extremely challenging. We used the shown blue, SU3. We even used the Carvel microcatheter with a Fielder FC. All this failed. So what do? We actually use the dual lumen microcatheter. We use a twin pass, and along with that, we use a Fielder FC. And I'll let this play because I think it's cool. And we finally crossed to the LAD. After that, we exchanged the Fielder FC to a shown blue with a microcatheter. And then with our DK crush technique, before we proceed with that, we decided to IVUS the circ because we saw some calcification. As you see in IVUS, the calcification is not circumferential, so we decided not to proceed with atherectomy. And this is just a demonstration of what DK crush is, and we'll go through that. So we started with predilation of both branches, main branch, side branch. We used a 2.5 balloon. Before we go to challenge 3, we predilated with angiosculpt. And then this is challenge number 3. We had a large dissection in the circ. And because we had the wire in place, we decided to proceed with the DK crush. We had a drug-eluting stent, a 2.0 in the circ, and then we post-dilated it with a 3 NC. And then we crushed it with a balloon that was already in the LAD. And then we did some, this is the crushing, and then we did dilation on the main branch, or another technical term for pot, but we don't have a stent in the main branch, so we cannot call it pot. And that sometimes helps rewiring the side branch. So we had our challenge number 4. We rewired the side branch, but we could not cross with any equipment. And the challenges we had here is that, are we crossing under a stent, or are we crossing not in the right strut? So what do? We rewired. We tried rewiring multiple times. We used fielder FC. Every time we cross, we cannot proceed with any equipment. So here's what we did. We used a very low profile Sapphire 1.0 balloon. And as you can see here, it has a very low crossing profile compared to all other balloons. And again, I'll let this play. I think it's pretty cool. So it finally crossed. Then we inflated it. We followed by a 2.0 balloon to the circ. And then we used the balloon LED to do our first kiss. After that, we placed the main branch stent with 275. It is, of course, sized to the distal LED, distal main branch. And then we did pot, followed by the second kiss. And before we do that, we did some IVUS to the circ. We found some mild under expansion of the mid-circ lesion, mid-circ stent that were placed at the dissection. So we post-dilated it, and this was our final result. So in conclusion, when there is a trouble with engagement, you can use a diagnostic catheter and then use a stiff wire to get your guide in. IVUS is very important for left main. And when you fail to rewire, POT can be helpful, twin pass can be helpful, fielder FC or any polymer jacketed wire can be helpful. And when you fail to recross, probably a Sapphire Pro would be very handy. Thank you.
Great case. Thank you very much for showing us the technique and everything, troubleshooting along the way with every step. I like your bifurcation technique here. Again, which branch is your main branch is always a question when both are about the same. This is a protected distal LED, so you're not, if it is unprotected LED, for sure you want to use the LED as your main branch. If it is protected, then depends on what you're treating. Here, they're about the same probably. So you choose usually the one main branch, the one that's going to be harder to recross. In this case, your LED was the harder one to recross. That's why probably you chose it as the main branch. You mentioned after you crossed that you could not do rotational atherectomy, but that would have been a problem because you had 2 wires, right?
So we did not choose to because the calcification was not circumferential. And of course, if we could use it, we had to take out the
right. So
LED wire.
So that's my point. If you decided to do rotational atherectomy, obviously you cannot do it with 2 wires, but there is a technique if you want to do it. If you have 2 wires, if you're working with a big guide, that's probably was an 8 French guide. You could put a 7 French guide extension catheter, guide liner, guidezilla, telescope, with 1 wire outside the extension catheter and 1 inside it, and send the rota burr over the one inside the guide extension catheter. So you shield the other wire from the way. That's just in case you have to, especially if the calcium is further downstream.
And there's another way to do it, which is to put a fine cross across the wire you want to protect and either do orbital or very small burr. But you need 8 French.
You know, Michael, very nice case. I was just interested, you know, we didn't have much insights on the initial diagnostic and geography, and I guess people may be wondering, with all patent grafts, you know, the need to do the bifurcation again. So I think it's a good point that even though patients may have flow and patent grafts to all territories, that sometimes one requires meticulous interpretation of the anatomy in case there's a diagonal that has completely revascularized, and what opportunities exist for improvement of symptoms. And I think it always, I think in bypass patients, all grafts are open. You know, sometimes it may be just a provisional to the LED, left main to LED, but you know, of course, that requires consideration of that.
And his OM graft had some proximal lesion as well, so.
But it is a good point, but to play devil's advocate, you know, the OM branches were occluded, and there's very little LV myocardium supplied by the circumflex here. So, you know, one could say medical therapy would be adequate for the circumflex, you know, area. Though, you know, it's an angiographically perfect result.
All right. Thank you.
Thank you.